Welcome everybody to this special Saturday edition of PMP Pals Hope Zoom. We have a very special guest, today, Shannon Alpeter, and what we'll introduce her in a moment. We've got a few new people, and we do have a few people that we haven't seen in a while. So welcome. We're so excited you could join us for this presentation. So with that, I'm going to take a moment to share my screen and to remind everybody what PMP Pals is all about. But just what we'll go through introductions, real quick. So, Adele Jason, 11.5-year survivor, board member, current board president. Charmaine.
Hi, also on the board and a 25-year survivor, live in Austin, Texas, and love being here with everyone.
Connie.
Hi, good morning, everyone. I am a volunteer with PMP. I'm also the caregiver for my husband over the past 7.5 years. Welcome. Nice to see everyone.
Jamie.
Hi, everybody. I'm Jamie. I am a thriving patient and I am an organ and a volunteer, and I'm happy to be here with everybody today.
So welcome, everybody. As I said, I will quickly share my screen. Okay, so as a reminder, PMP Pals is the world's oldest global volunteer-run organization that gives hope to patients and caregivers fighting appendix cancer, or PMP. A couple of disclaimers we want to cover for this meeting. We provide forums for fellowship and support, but we're not licensed medical professionals. So we encourage patients to seek licensed physicians who are qualified to develop and provide appropriate treatment plans. We do have a medical professional presentation today, and sometimes there might be graphic or scary images or data. Participation in these forums means that your identity and health condition might be shared with the public. You're welcome to anonymize, turn off your camera, change your name. We are recording this, and since it is a guest presentation, we will publish this session. Just a couple things about PMP Pals. So, two of our most popular programs are these Hope Zoom calls. We have these twice a week of sharing fellowship, sharing ideas, offering hope and support to patients. And every few weeks we have a guest, and we have a guest today. Our most popular program, our legacy program, is Get Well cards or cards of support that we send to patients and caregivers. We also have a program where we also send our cute little bottom bear to patients needing a little boost. We do provide one-on-one support, and many in this group have connected with others in this group on a one-on-one basis in addition to our group calls at Hope Zoom. You can reach us at info@PMP Pals on social media, Facebook, and at pmppals.net. And, we are totally, volunteer run and donation driven. And so, we welcome any support, and that there's a link on our site. So with that, I would like to introduce our special guest, and I have your bio up here. I am going to talk about all of it because it all deserves mention, Shannon. So it is our pleasure today to welcome Shannon Alpeter, who is a certified physician assistant in the UPMC division of Surgical Oncology. She earned her undergraduate degree, BS, and master's degree in physician assistant studies at DeSales University in 2011, and she's currently in the process of obtaining her doctoral degree at the University of Lynchburg. She's a senior PA in the outpatient setting with Dr. Haroon Choudry, and many of us know Dr. Choudry, and first assist in the operating room. Shannon has spent the majority of her career in surgical oncology with past experience in trauma surgery. Within her current department, Shannon has developed the educational resources available to patients undergoing CRS HIPEC, and you'll see some of that today. She conducts chart reviews of new patients for the Peritoneal Surface Malignancy Tumor Board, collaborates with UPMC's patient liaison team to publish patient survival stories. She's been a preceptor to many students and residents since 2012 and has been awarded Preceptor of the Year award. In 2019, Shannon expanded her educational role by becoming an assistant professor at Chatham University as a problem-based learning instructor. And she's held various certifications. I'm going to read them all so we can recognize you, including BLS, ACLS, ATLS, FCCS, Da Vinci Robotics, and UPMC Surgery Coach. And again, we are so honored and privileged to have Shannon here today. And, this is going to be a little bit of a spontaneous session. There were some advanced questions that were provided, that we've provided those to Shannon. So Shannon's going to address those and give an overview of, some of the questions she answers on a day-to-day basis. And, we'll keep it interactive and spontaneous, although in trying to manage these people, as people are talking, if you're not talking, please mute yourself so that we can listen to the conversations. So with that, I will turn it over to Shannon.
Thank you, Adele. That was very sweet of you. And thank you, PMP Pals, for having me. I am humbled by this experience, so I'm happy to be a part of it. So as Adele said, I did receive a few questions in advance, and I would like to start with some of those common ones and transition to some of the other more common or repetitive questions. And it actually kind of is the same way that I address a consultation with a new patient. I think we should start with the clarification and understanding of one's diagnosis. So there was several questions about what my appendix cancer is and what is PMP and those differences. So I think we should start there. There are various tumors of the appendix. So that's your primary tumor. And the majority of patients in this network obviously also have PMP, which is its own separate entity. So it is important to distinguish those two processes. So there are various primary appendix tumors, and they are broken down into various categories. And some of this may be a little bit more advanced, but I find that many patients want to know the differences because it leads to the differences in your management and your treatment. So one of the first are mucinous neoplasms of the appendix, which are, I think, a little bit more talked about and a little bit more common. So your mucinous neoplasms are your lamins or your low-grade appendiceal mucinous neoplasms. There's also a high-grade appendiceal mucinous neoplasm, and then your mucinous adenocarcinomas of the appendix. There are also another subgroup or another category, which are your non-mucinous tumors of the appendix, and these are adenocarcinomas. They look very similar to colon cancers. And then you have these epithelial neoplasms that have neuroendocrine features. So they can be a pure, just called what's a neuroendocrine tumor. And then there's your goblet cell carcinomas. So I'm sure everyone's kind of heard maybe some of these terms or even has this diagnosis. So that's your primary tumor of the appendix. And again, categorizing them helps you understand your future management and your treatment. And those primary tumors then are on the surface of your peritoneum, which is the lining of your abdomen and your pelvis. That can be referred to as PMP or Pseudomyxoma peritonei. This encompasses several of those primary tumors, and that also has categories, which is low grade and high grade, and then they're divided up a little bit more. So you can have your G1, G2, or G3, and that just is your grades. So you can have low grade PMP, intermediate grade PMP, high grade PMP. And again, it's its own separate entity and should be looked at that way and have its own classification and grade. So that was a lot of those questions too. I hope that clarifies a little bit how to look at each of those categories because it does make a difference.
Yeah, Shannon, one question that patients often ask, they get told they have stage 4. Can you talk a little bit about how stage 4, how it applies to this disease, this diagnosis?
Sure. Stage 4 is a very scary term, an overwhelming term when you first hear it. But I think it's important to realize that sometimes you're comparing it to common tumors like colon cancer, breast cancer. And yes, it's a devastating word to hear sometimes. In PMP specifically, all stage 4 means is that there is a distant metastasis, okay? So you have your primary tumor that is no longer its sole source of cancer, okay? It now has metastasized or moved, spread, these are other terms, to another organ, and your peritoneum is considered that. So yes, that's why a lot of people are told stage 4. I just don't think it's a very important term to use in this setting as it is with other cancers, because PMP is its own separate entity that has different management and treatment, unlike stage 4 diseases for other cancers.
Very helpful. Thank you.
Of course, yes. And there was one specific question: do I have appendix cancer after my appendix is removed? I thought that was a very thoughtful question. And I think it's important as you as the patient to know that, yes, if you are in that small group of people that you had a low-grade tumor, it was confined to your appendix was removed, there was no evidence that it had left the appendix or anything, then yes, you can say that you had appendix cancer or you had an appendiceal tumor. But even our patients here that have PMP and your appendix was removed, we technically use that diagnosis that you have or have had a history of that tumor. So I think it's a bit of a semantics, really, of just wording. And even when you have PMP and you have a surgery and everything is removed, I think technically we all say had a history of PMP, had a history of appendix cancer or various tumor type. So I hope that helps a little bit with that question. And then the other one was, what is PMP and is it cancer? I hope I addressed that yes, PMP is its own entity and it has its own grade, which is what we call histology, its own description, its own management and treatment. And I think this leads to that next question. Why do some people get chemotherapy and I didn't? So that comes down to how I started this conversation is it depends on that original tumor, first off, and then what is your grade of your PMP? In some cases, you can have different histologies. It's very rare, but it can happen. So that's why it's very important to distinguish the two different entities, which is your primary, and if you have PMP and what grade of PMP that is. I think this is a very good question to ask an oncologist if this pertains to you. And even if you don't think it does, it's a great question to ask about your treatment to make sure it is well-rounded and that your treating team is considering all options for you. So when it comes to chemotherapy, in general, we know chemotherapy does not penetrate the peritoneum as well. So it may not work as well for peritoneal disease, but it is still worth it in some tumor types. So it does work well in your adenocarcinomas. We don't have any data to support it working in low-grade neoplasms. So in general, it is not used, but we also don't have data that supports it. So I think that's a good general way to answer that question, that you should ask this of your treating team. Do I qualify for chemotherapy, and what supports that use of chemotherapy, and how well will it help me? So those are very good questions to ask your oncologist if you're considering systemic therapy, right? So chemotherapy is systemic therapy. And then I think the what is the difference between adenocarcinoma, neuroendocrine tumor, and other forms of appendix cancer? I hope I addressed that for whomever asked that question. It's a very technical question. I think, again, important to ask because it does direct how you are treated and what your management will look like. It is a question that you should ask an expert panel of people who treat peritoneal surface malignancies. And then I think this leads us then to actual treatment and management. So in general, cytoreductive surgery in HIPEC or CRS HIPEC is considered standard of care for low-grade PMP and then other forms of PMP as well in conjunction with other treatments. So I apologize, it's going to be a long-winded answer because we have to address all forms. Excuse me. If anyone has specific questions about that treatment and management, I'll address it, but I didn't get any ahead of time. So I wanted to address the ones that I did get it. So a lot of people who weren't sure what to eat before surgery, after surgery, when it comes to undergoing CRS HIPEC. I think this is very important to address. And at my institution, in our practice, prehabilitation and post-habilitation are very important key aspects of your care. 4 to 6 weeks is optimal. Not everybody has 4 to 6 weeks to plan before CRS HIPEC. So you take what time that you do have, focusing on physical prehabilitation, nutritional, as well as mental. So I do like to break it down into those 3 categories in order to prepare patients for CRS HIPEC. And it really comes down to you and your provider and your team, what you think you may need, because not everybody needs the same. So you address those needs as they arise. So first off, you bringing the best you to surgery and giving some of those concerns like, is surgery going to go well? Is it going to work? Give those concerns to your treating team. Because if you can focus on your rehab and maximizing your health, preparing yourself for that surgery, you will and can have that possibility, decreasing postoperative complications, increasing your recovery time, and making that choice to have the surgery worth it for you. So mental health, I think, is definitely something that you need to start on before you even start this journey. So I don't think we talk about mental health enough. Establishing yourself with a health coach, a mental health coach, a psychologist, whichever group member that you want to visit with, start it at the very beginning. They need to go with you through that whole journey. We do know that patients are more likely to have depression with this diagnosis and after this surgery, whether that's a temporary diagnosis or longer term. So having a mental health coach on your side is, I can't recommend it enough. Not to mention, yes, your family is a great support, your friends are a great support, but that third party member has something to offer that I think is key to your whole journey through this. And then your physical health. So that's your nutritional health, exercise, and your medical conditions as well. So we address those as well in the pre-surgical period. Again, if we can maximize or optimize those issues prior to going to surgery, having the healthiest you come is much better than having someone who is frail, where you don't feel like you physically can go through this. I'm sure a few people will remember the way I describe it to patients is that you're about to run a marathon that you've never trained for. So if I can help you a little bit in doing that, I would like to do that. So nutrition-wise, honestly, I get questions all the time. Do I have to increase my antioxidants? Do I need to decrease how much sugar I'm eating? You can do these things if they bring you comfort and that you feel that they are having an effect on you. But I don't have the secret, and I don't think anybody does really. A well-balanced diet is there to support you. There is a lot of literature out there, though, regarding prehabilitation when it comes to nutrition. If you have 4 to 6 weeks to prepare, protein centered so that you can increase those stores to help your body survive something as stressful as a major surgery. And then a lot of people like to recommend in these enhanced recovery programs, about a week prior to the surgery, you carbo load. And I do describe that to patients like you're an athlete in college getting ready for the big game. Okay. So yes, you can lots of pastas, but I prefer the whole grain pastas. They are better carbs and like bright, colorful fruits and vegetables. These are all the good carbs. Again, that's going to give you the immediate energy that your body needs to break down and use in order to give it the energy it needs to get through that surgery. Right? Remember, it's a marathon you've never prepared for. And then medical. So various patients, they're like, oh yeah, I have high blood pressure, but it's managed. Let's make sure that it is truly managed. Okay. So even something as simple as high blood pressure, we're going to check in with the PCP well in advance before the surgery and make sure that all of your medical issues are optimized. Sometimes something like diabetes, you check your sugars every day and they're fine, but we got to make sure we check your hemoglobin A1C. Check in with your cardiologist. Did your EKG show something that hasn't been there before? An echo, a stress test can sometimes be needed in some patients before this surgery. So again, these are the various testings and avenues that myself and our team in our practice that we make sure that we explore before undergoing this surgery. Not everyone is going to have something abnormal, but the couple of people that we do find over the years, it's totally worth doing and undergoing this preoperative workup to make sure that your medical issues, your conditions are optimized before having a major intervention. So it's mind, body, health, nutrition we went over. I'm not going to ignore hydration. So you need to hydrate even before surgery. And then exercise is another endeavor that can sometimes be hard. Not everybody is in a position to exercise before this surgery. Like I said, not everyone has 4 to 6 weeks to prepare for surgery like this. And some patients are in chemo and they just can be already run down. So something as simple as taking 20 minutes for a brisk walk 3 times a week can actually increase your physical endurance before a surgery like this. So that's usually where I would recommend starting. You don't have to do this major exercise routine where you're lifting weights, going for runs. It can be something as simple as a brisk walk for 20 minutes, 3 days a week. And some people can't do that, and we'll make adjustments. Unfortunately, I have to speak in averages, but yes, I've had patients where we have to be unique, and we'll do that. You can always find a solution. We'll find one. So I think that was the majority of prehabilitation. Again, breaking it down into categories, make checkbox for yourselves. It can be helpful. And if you'd like, I actually have a little checklist I can share with you.
Please.
So this is the patient education booklet that I came up with our team to help patients prepare for cytoreductive surgery in HIPEC. So again, I break it down into chapters to make it well organized so that you can focus on whatever chapter of your journey that you're on. Because if we went over everything all at once, it's too overwhelming. I think breaking it down into chapters helps you prepare and get through this. So the preoperative part, I think I just went through with you. Sometimes we don't think about, when we're focused so hard on how do I get through this major surgery, we forget about some of the other things that could be minor or major for you. So another checklist, is someone going to take care of your medical bills while you're going through this? Or who's going to help you with that? Do you have a financial planner or someone that you can assign this to? Simply checking your mail and making sure that these things are met. Having a living will or advance directive. I find it a little surprising how many people don't consider this. So I do think that is worth discussing, especially undergoing such a major procedure like CRS HIPEC. Yes, in our institution, the rate of mortality, so the rate of dying at the surgery or within 90 days is less than 5%. But I still think that's a significant number, that's something that we should address. And not to mention, there are complications. 1 in 3 patients are going to have some kind of major complication. And that may mean you need a tube of some kind, and you may not want that. So having an advanced directive or a living will can be very helpful in these situations, and helps you also break down what do you actually want to have done and understand the magnitude of this treatment journey. Caretakers, pets at home, children, plants. So you may want to assign all these things to someone. Having a driver, very, very important, not only to the surgery and from, but that first 6 weeks after surgery, 8 weeks even, you may not want to, and you may want to get out of the house and go to the park, but you're not going to be ready to drive. So having someone that you can rely on just for that. And I do highly recommend asking in your region for what are some of the cancer research groups, foundations that offer money specifically for this. I know here in Pittsburgh, we have what's called Cancer Bridges, and they offer money for this too. So I know if you look around locally, there are funds to help patients. We went over exercise. Smoking and alcohol cessation can sometimes be touchy, but I do think it's something to breach. These are important. They will make a difference in your surgical outcome, and something to discuss and bring up. Packing personal items. Sometimes we don't think about it, but bringing a blanket that's comfortable for you, comfortable PJs, you can be in the hospital for a couple of weeks. It makes a difference sometimes, not to feel so isolated. Obviously, fertility for men and women. I think this is extremely important, especially with more and more young people getting this diagnosis. It is important to discuss your fertility. Even before you have chemotherapy, if you're in the group of patients that are going to have to undergo chemotherapy, I'm sure your oncologist will go through this. If not, ask. And if you're going straight to surgery, again, ask. Unfortunately, yes, HIPEC is meant to stay within the cavity, within that bubble of your belly, but in some cases, a small percentage of it can become systemic. And not to mention for women, unfortunately, the ovaries is a place where sometimes the cancer metastasizes too. And if that is the case, the ovaries have to be removed. So again, not something that you want to once again think about. Why is it one thing after another? I already have a cancer diagnosis and have to have a major surgery. Why do I have to worry about fertility? But it's better to have it up front than to wonder why after the fact when you don't have that option anymore. So there is ovary banking and sperm banking available. And then lodging, that's another good question to ask your team when you're preparing for this, is where can I stay? Where does my family stay? Do they stay in the hospital with me? How close is it? How much does it cost? So that was, I like that little checklist to help think of the things that you are not concentrating on in that moment. Okay, and then I really, really enjoyed this question. When should I call my surgeon, my PA, and my general practitioner? So I think you need to establish with your team. I can only speak obviously for my practice and my team, and I encourage you to ask these questions with your team. I am a PA myself, a physician assistant. I love my profession and my career. I have an excellent relationship with my attending, who is a physician. I have an excellent relationship with my nurses and my colleagues that work at other institutions. So I think obviously when you meet with your team, that is something that you'll assess and make your own opinion. For me personally, I encourage my patients always to call or email for whatever reason, and then I can help direct where that should go. So first, in general, I think you can call your PA with any question. I think that they should be a resource for you that is an honest one, that'll help direct you to where you need to go. Myself as a PA, I was trained that I have a scope of practice and I need to be able to identify and be reliable to identify when something is outside my scope of practice. So if there is something complicated or it's going to be a major treatment decision, we collaborate with our attending. So that is called team practice. And I think if you have a PA or a nurse practitioner on your team, I assume that they will do the same thing. Now, obviously, yes, are there less than average people in all careers? Yes. So ask the questions. I encourage you to ask those questions. You can ask hard questions of your team, and that'll help you lead you to that. So myself and my practice, I hope that, again, I am a reliable source for my patients. You can ask me those hard questions, and that I am reliable, that if it's outside my power to answer for you, then I'm going to involve the team and find you the person who can answer that question. General practitioner, though, I highly encourage you through the entire journey to stay in touch with your PCP, your primary care provider, your general practitioner. So yes, your surgical team is, and again, I speak from, because that's my team, your oncology team, your medical oncology team, they're experts at what they do. But your PCP is an expert at what they do, and they manage you top to bottom. They know you inside and out just as well as we do, but again, ours is a little bit more tunneled towards your cancer and how we're treating you. So your PCP and your general practitioner should definitely always be intimately involved in your care from beginning to end. So I think they're a very helpful resource and always should be there for you. Let's see. And then I have a couple more questions that were, on their own. If you would like me to address some of those too, I can go through them.
Sure.
So I think one patient sent in that they were told a CT can't tell the difference between dead cancer cells, live cancer cells, and scar tissue. So CTs are a very good resource, a tool that we use in order to help diagnose, manage, surveil, follow patients with appendix tumors and PMP. It's not a perfect tool. So I do think there is truth to that statement, that CTs are imperfect, that sometimes it is hard to tell, is this a cancer recurrence or is this scar tissue? And so with these tools, you combine them with other tools. How's the patient feeling? How are you doing? Are you having symptoms? Which again is not perfect or reliable in its own. And tumor markers, but again, tumor markers aren't reliable on their own either. These are helpful tools, and you need to combine them if they are helpful in that case. So CT scans, no, it does not tell the difference between what is a live or an active cancer or an inactive cancer versus scar tissue. But there are signs that these expert physicians and teams can read. For instance, if you get that CT scan and 3 months later, if an abnormal nodule is growing, so that's a suspicion. And then there are other things like sometimes the small bowel can look tethered or dirty. These are signs that this could be an abnormality on a CT scan. PET scans can be useful in some cancers. In general, in PMP, not always. And again, this is through the literature what has been established as helpful tools. MRIs are another helpful tool in these cases. They can be a little bit more sensitive in detecting PMP. And then some other questions about like, when do I know when to have a diagnostic laparoscopy? So there are expert consensus groups that have come up with these guidelines that help your treating teams decide, and it is based on a case by case basis, all right? And it's something that you can discuss with your treating team. So that question I highly recommend is a question for you and your treating team, if, again, to analyze it on a case by case basis. Ask those hard questions, read your own reports. So and trust me, as a provider, I don't like it when my patient gets to a CT report before me, but maybe read them together. Look at the images together. I highly recommend that so that you have an understanding of how this decision-making is going, that if there is a suspicion on your CT, why is it suspicious? And is it okay to look at it again in a few months? Or is this one of those times where your surgeon should go in and look themselves? So those are questions to take personally with your team. because they are good questions to ask, and there are ways to help figure it out. But no, there's no black and white answer when it comes to that. And then if you give me one moment, I think Adele sent me a separate email. Do we know how long lamin or low-grade appendiceal mucinous neoplasm can take to grow? I cannot give you a specific answer. I can tell you that low-grade appendiceal mucinous neoplasms are extremely slow growing. And it is the minority of patients that present with a primary tumor that has not perforated. I think it's less than 0.3% of all appendix removal, so an appendectomy, present with a tumor. Less than 0.3% of appendectomies. So this is very, very rare. That's again hard to tell you. We do know in low-grade PMP, it takes years for that to grow. And there are going to be the majority of patients that present with a tumor from the appendix, a low-grade mucinous neoplasm that has already perforated. And you can't, there's no one to blame or ask or why. Unfortunately, there's just no symptoms sometimes. And then they present with these mucinous tumors that have accumulated in their abdomen and pelvis. So sorry, I can't give you a specific amount of years, but it is many. When the specialist can't find any evidence of disease, how long should you wait again before you try to get it looked at? And I would like to reflect back to the conversation we were just having. This is very specific to each case, each patient, in each treating team. So always don't hesitate to ask the hard questions of your team. So I hope that's a big takeaway from today, is ask those hard questions. It is in the literature still debated, still talked about and encouraged in that same way. So if I get a new patient who's coming to us for a second opinion, I dissect through that entire record and we present it to our tumor board and we discuss exactly that. So we take it on a case-by-case basis. We look at all the CTs, the MRIs, the tumor markers, what treatment you've had done, and consider whether or not it would be beneficial. And even in our established patients, if we're watching something on a scan that looks suspicious, we're not sure. Again, it's something that you consider. So ask that hard question of your case with your team. And then Adele and PMP team, was there any other questions? I think I saw a couple pop up as we were talking.
Yeah, so we do. I'll start at the top. So a newly diagnosed goblet cell patient. Two questions related to that. What can this patient expect during their first year after diagnosis, and what things should this patient and their family know?
So, yeah, that is a difficult question to ask, and thank you for asking it. In general, goblet cell carcinomas of the appendix are a more aggressive or higher grade tumor. If it also then has the peritoneal disease or peritoneal metastasis, that is a high grade PMP. So in general, I think we have to look at it from that perspective. That first year is a case-by-case basis. Is it the primary tumor or is it with PMP as well? I will speak to the PMP part of it. Being a higher grade tumor, you're going to need multiple people on your team, is what I can encourage. You have an oncologist, a medical oncologist. You ask what your systemic options are. Goblet cell carcinomas do have that potential to be invasive, more aggressive, and not necessarily are they confined to the peritoneum or the surfaces. So they do have the potential to be more invasive. So ask that hard question of your oncologist. What are your options? What are the probability of them working? And what are the backups when they stop working or aren't as effective? Have a surgical team. Again, explore those options of what surgical intervention could be. And if it isn't an option, what are the alternatives? And then I highly recommend a palliative care team. And I use that word cautiously. Palliative care does not mean end of life. It means symptom management. Goblet cells can be a little bit more aggressive. They can be more invasive, and you can have complications associated with that. And that goes for all PMP. It is a hard diagnosis to carry. So I think a palliative care or a symptom management team is essential. I do think you need all members to help address that.
Okay. Another question, a low-grade patient that could not have a complete CRS HIPEC, and you had mentioned earlier that systemic chemo is typically not part of the treatment plan for a low-grade patient. So what sort of treatment plan or management should a patient in this situation be looking at?
So this was a low-grade PMP specifically? Okay, so I do want to make sure that's heard. This is low-grade PMP specifically. There can be alternatives in low-grade. So if you're not deemed a surgical candidate, I highly encourage, and it should be encouraged, to seek a second opinion and to make sure that you are not a CRS HIPEC candidate. With that, a second opinion, also look at these other institutions that are exploring alternatives to CRS HIPEC in low-grade PMP specifically. So there are various treatments that are re-emerging and being explored and researched. So again, this is not standard of care. This is not widely done, but it is being researched. So EPIC is one. It's called early postoperative intraperitoneal chemotherapy. It's being looked at to be in combination with CRS HIPEC. Patients that cannot have CRS HIPEC, transplantation is now being researched and conducted. There have been a few cases, and when I mean a few, 11 in Europe, 1 in the United States. Okay. So again, ask those hard questions of your team, do the research. PMP Pals network obviously is a huge resource for that, to keep asking these questions, to bring light to it. And then there's also mucolytic therapy that is being explored for this. I'm sure some of you have even heard of Bromac out of Australia, and it is coming to the United States. These options are being explored for certain groups, even in low-grade PMP. I know it seems unfair that something that's already so rare and so small has to then be broken down even smaller. But these treatment options that are being researched and explored do not apply to everybody. I was fortunate enough at our institution, I treated 5 patients this past year with Bromac. So it is an option. It will be here soon. Hopefully that trial opens up soon. Ask if you qualify for any of these alternatives, and ask for that second opinion to be evaluated if you are a candidate for these alternatives.
Okay. We have another patient, Shannon, that had their surgery. Their surgery was aborted, due to small bowel involvement. And this patient has had 75 weekends of chemo, and is quite exhausted. Is the exhaustion because of the chemo or the cancer? And could the every 2 weeks potentially be pushed to every 3 weeks?
Very good questions, and I do hope you explore it with your team. But to help address that and guide you, first, I'm sorry that your surgery was aborted, and I hope you have continued strength and success with these treatments that you're getting. Yes, chemo regimens can be adjusted, and your reaction and how well you're tolerating them are taken into account. So ask your oncologist specifically, say that you're not tolerating it very well. Can it be adjusted, the regimen? And what is the probability of it still helping you when that happens? So yes, it may be an option, but I think you also need to ask that follow-up question then, how does it affect your treatment when you adjust the regimen? And then what was the other part of that question, Adele?
Is the exhaustion from the
Oh,
chemo or the
yes.
cancer?
In general, it's usually a combination of things. PMP, just yes, I make it sound like it's just sitting on the surface and it's not that invasive, but it definitely affects how all of these organs are working and whether or not it continues to work in its normal fashion in concert with the rest of your body. So yes, it's going to disrupt your nutrition. It's going to disrupt your GI flow. And when that's disrupted, it takes away from your nutrition, which takes away from your endurance, adds more fatigue, brain fog. So it's a combination of the tumor and what the tumor is doing to your body, as well as the chemotherapy that you're taking in. Yes, chemotherapy is designed to kill cancer cells, but unfortunately, it also hurts healthy cells. And we do know that. So again, I don't think any complaint is too small when it comes to undergoing treatment. If your nausea is worsening, do not tough it out. It's okay to monitor it for a day or two and then report it to your oncology team. So I emphasize that with my patients all the time. Please don't think you have to tough this out on your own and that it's just an annoying complaint. I want to know what is annoying you. I want to help address it because I might have a little trick or something to add that you haven't tried, or another patient, share it with them in this kind of network, in this community. They've been there, maybe they figured out something that could help in this situation. But especially your treating team, because obviously they're going to have a lot of tools and resources for you to help get through that. So yes, undergoing treatment when you have PMP and all of that is affecting you, I think you need to use every resource available to you in order to maximize your health, your endurance during that treatment.
Thank you. Can you speak to a Signatera blood test to detect early recurrence?
Yes, so Signatera or Natera, which is ctDNA, very up and coming, very interesting, very exciting for you as the patients and us as the providers. It is not standard of care, okay? So I can't emphasize that enough. It is still being researched. There are very interesting and very exciting data that has been released already. It is not perfect in every tumor type. And I know this is always so disappointing for me to say because I say it every time. It doesn't appear, it may not be as beneficial in PMP. Because again, mucinous tumors, the peritoneum, we may not get the same results, but that does not mean it's not going to be researched or explored. So in general, for those who don't know what ctDNA is, this is a tool that's being researched as part of surveillance treatment management. Okay, so right now we use scans and tumor markers, which is a blood test, but they're not perfect in everyone and they're not perfect on their own. So what's another minimally invasive way to measure tumor in one system? So it's a simple blood test that they then match to your tumor. So it's specific to you. Your Signatera or your ctDNA will look completely different from the next person's ctDNA. And that's what they do. And they measure your blood test every so often, and they measure that and they give you a number. So it's either not detected, or then they give you numbers of how much is detected. So yes, up and coming, very exciting. But again, it is not currently recommended to be used in treatment management or decision making. It should be done on a research basis on a trial. But yeah, I have patients that have it and it's very exciting, but I don't rely on it just yet, not yet, and not in PMP especially. But I think it's something that we should continue to look into.
Thank you.
Mhm.
You responded to a question about how quickly low-grade tumors grow. Could you address how quickly high-grade and maybe even more specifically, signet ring and goblet cell?
So I am not going to give a specific number on those tumors. I do think you need to ask your treating team what those specific numbers are. Every major institution or high volume center that treats these tumor types are going to have an answer for you, okay? And I specifically do not like giving them out to general groups like this. I think that is a very personal discussion to have. So I can tell you in general, I'm not going to leave you completely high and dry. The higher the grade of the tumor, so a grade 3, these are more aggressive, they're more invasive, they do recur sooner, they do recur quickly. Goblet cell carcinomas are also part of this group. They are very aggressive, they are very invasive, they can recur quickly. All the more reason to get into a large team who treats peritoneal surface malignancies and has multiple experts in that group: medical oncology, surgical oncology, expert pathologists. That is key to this as well, to make sure that is the accurate diagnosis. And then I think you need to ask that institution and that treating team, what is that number? If you truly, the individual, the patient wants to know that number. I caution, I don't want to ever hide information from a patient. I'm very direct upfront with what you may want to know. But I think you really need to ask yourself, because we know those things in general, that they are quicker and they return. I don't want an expiration date to ever be on the table, but also balance that with the fact of being realistic. I think the answer, or the question that you really want to know, is how do I live the life that I do have? How do I prepare for end of life while I'm enjoying the life that I have? So I would take those questions in that direction with your team specifically.
Thank you. Does Zolida help a low-grade patient after they've already been through 2 HIPECs and are now experiencing recurrence again?
Very good question. Whomever asked that, thank you for asking. So low-grade PMP, again, generally we do not do systemic therapy, right? But sometimes when you have these expert groups, these high volume centers, you have to push the envelope, right? You've already had 2 surgeries, multiple CRS HIPECs. You want to delay having another one, or you may not want to have another one. Xeloda is a form of chemotherapy, comes in a pill. It's also capecitabine or 5-FU, or very similar drugs. So yes, I can say that they have been considered. It is not standard of care. It is something that you need to have an honest discussion with your team. That is there evidence, or what is the probability that it might help? But honestly, is it going to help? Are we going to watch and see if it can help? So those are good questions to ask, but I don't want everyone to think that low-grade PMP gets treated with Xeloda. It doesn't. It's one of those case-by-case bases that we've explored or done and repeated the treatment options. Can we think outside the box? Can we push the envelope a little bit and see if this is going to help? But no, currently, like I said earlier, obviously a very good question for an expert oncologist, but systemic chemotherapy is not part of standard of care for low-grade PMP.
Thank you. If the appendix ruptures, is it automatically considered PMP?
Oh, another excellent question. Again, we're getting down to the nitty-gritty of this diagnosis. And it's important because I've had a recent increase in patients that are presenting exactly like that. So remember I said earlier that it's like this minute fraction of patients that have an appendectomy and there was a tumor in there. Or they present with appendicitis, and on CT scan, they see this mucinous collection within the appendix. So that's most likely a mucinous neoplasm, or their mucocele, or some of the other terms that are used. So in these situations, a surgeon will remove the appendix, and they also take a look around. The pathologist then will tell you whether the tumor was confined to the appendix or if there was perforation or a penetration of the wall of the appendix. So this is very, very important. This is exactly what we discuss in our tumor boards when it comes to tumor types like this. Was it confined, or was that wall disrupted? Was it penetrated? Because it's just a hot topic. And if you look at expert consensus groups from Europe and the United States, which is the Chicago's consensus guidelines for management of peritoneal surface malignancies, it is important to distinguish. If that mucinous tumor has penetrated that wall, you want to know exactly, is there mucin outside of it? Is it just on the surface of the appendix, or was it anywhere else within the surgery itself? And then was it acellular or cellular mucin? So again, that attests to the beginning of our conversation regarding grade. And then you go from there, case by case basis again, and you decide whether or not you're going to watch and wait with scans and tumor markers, or if you're going to plan what's called a diagnostic laparoscopy at some point. Again, these expert consensus groups recommend that you consider this. It is not necessarily standard. But again, at our institution and in my practice, we get a lot of second opinions. So it is considered a lot and talked about more. And we give it to the patients as an option. We say, this is the data, the literature that we have. These are the two ways we can go. And we make that decision together. So I think to answer your question, if you have a tumor that has penetrated the wall of the appendix, read your path report, ask those questions again, seek opinion, a second opinion if needed. If there is that perforation and mucin outside, you can consider your options and what your goals of care and which of those treatment options fit your goals of care the best.
Thank you. Are Guardant 360 blood tests helpful?
Yes, absolutely. So I think I put a lot of emphasis again on having primary tumors. And if you have PMP, have your PMP examined by expert pathologists, because that histology or that tumor type, the grade, makes a huge difference in your management and treatment. So yes, exploring these other, Guardian 360 is its own company. There are other ones as well that do tumor genetics. So this also helps us understand these tumors further. There can be tumor mutations that can be targeted or can give us a further understanding of the biology of the tumor or the disease process. So yes, I don't have one favorite, but I do favor next gen sequencing or sequencing the genetics of your tumor.
Thank you. We have a patient that has a diagnosis of Lamin and PMP with an upcoming CRS HIPEC at the end of the month. Should this patient know what their tumor burden is and their PCI score, before their surgery, or will that be found out during surgery?
So you can try and make a guess based on CT or MRI. It's an educated guess on what your PCI is. And for everyone, PCI is your peritoneal carcinomatosis index score. This was created decades ago. It is a organized and agreed upon way to measure your tumor burden or how much tumor is on the peritoneal surfaces. So yes, you can make an educated or approximation of what the PCI is. It does help your surgeon surgically plan, okay? And in some cases, it really depends. You have to discuss it, because if it's low volume, intermediate volume, high volume, it really tailors that discussion of what is your surgery going to look like. So I would encourage you then to ask your surgical team, how much do you think, or what is the approximation of my volume, and how is that going to affect me How is that going to affect you as the surgeon in my surgery? Does that mean that I'm going to have more organs removed? Does that mean that it's going to be a longer surgery? Am I at risk for more complications? So again, knowing that ahead of time, I think is beneficial to patients if you're that type of person that wants to be able to prepare for all of this. And I do include that in our education booklet for patients. So what does cytoreductive surgery look like? What can it possibly entail based on my volume of disease? So I do go into what organs can be removed, how are they removed, and what does that mean for me? What are those possible risks? So your pancreas can be operated on. How is that done? And how does that increase your risk? I definitely think that needs to be discussed before you go into surgery, because it's a lifestyle change, a behavioral change after surgery, and something that you need to be accustomed to when recovering. So what does that look like? What does it mean to have your spleen removed? What does that do for you? And also this one, can your diaphragm have disease on it? Yes. Does that need to be stripped? What does that mean for you? Does it increase the risk of my surgery? Does it increase my recovery? What kind of complications? How can it change my life? So there are a lot of questions that can be brought on by knowing your disease volume going into surgery, and to ask your surgical team. Something as simple as having your gallbladder removed can be, seems simple, but when you combine it with everything else going on, you need to know what's going to happen. Multiple bowel resections is the biggest part of CRS HIPEC, and ask what that means for you, and ask your surgeon, how much of my bowel do you think is going to be removed, and how is that going to affect me? Sometimes your stomach is involved, and parts of your stomach need to be removed. So I know we didn't get to go into post-operative recovery at all. Happy to discuss further if anyone ever needs to. These are very good questions for your treating team. But again, knowing those complications also prepares you for your recovery. So I do think those are good questions to ask.
Yeah, so along this current discussion, could you address the CCI score with CRS?
Oh, yes. So with, again, standard PCI, peritoneal carcinomatosis index, goes from 0 to 39, 39 being the maximum volume. Then how do you measure the volume that you've removed? This is your cytoreductive score or completion score, and that can be measured as well. So a CC0 means that no visible disease is left behind. Again, this is a measurement for surgeons, and also we share it with our patients to help them understand what their recovery and future prognosis is going to look like. There's also a CC1, which is visible tumor that's left behind that is less than 2.5 millimeters. Okay. And then you can have a CC2, which is 2.5 millimeters up to 5, and a CC3, which is then visible disease that is 5 millimeters or greater. And in general, in cytoreductive, again, this is in general, cytoreductive surgery, usually a CC0 is then when you get HIPEC, and then again, case-by-case basis, whether or not there's visible disease left behind, and you get HIPEC with that.
Are ostomies being used at the same rate as before, or are surgeons trying to reduce that?
So I think this is a case-by-case basis, again, an institution to surgeon. Ostomies aren't something that we give because. So an ileostomy or a small bowel ostomy, we use if we think that's what's going to save the patient and help them recover, to decrease possible complications after surgery. If you've had multiple bowel resections, if you had a bowel resection deep in your pelvis, these are high-risk connections. So yes, an ileostomy, a temporary one, can be used in order to give your body the time it needs to heal and decrease possible complications associated with those new connections. I think permanent colostomy, so ostomies of your large intestine, case-by-case basis, and again, aren't just given. It's a discussion that you're going to have about whether or not it's the probability of you needing one. Sometimes if there's a lot of disease deep in the pelvis that involves the colon, if it's going to be a high risk connection. So again, case by case, But yes, ostomies still exist, and each institution and surgeon is going to have their own probability or chance of them happening. And even then, if they have an average, it's really comes down to you and what your disease looks like and whether or not it's going to benefit you.
For a patient that is having a second CRS HIPEC, what questions should they ask? And with the patient not wanting tubes, not wanting a lesser quality of life, does this patient have input in terms of what will happen to balance the quality of life with going through the second surgery?
Yes. So in general, there are more risks every time you go in. There can be possibly more complications on repeat CRS HIPEC. So again, I would be acutely aware and ask those questions on how it affects you when entertaining that option. You said like tubes. So I think it's a difficult conversation when you start saying, yeah, I want to have another surgery to have the disease removed, but don't remove this organ and don't do this if it's going to mean I need an ostomy. That's a very hard, red tape to put around it. So I think, again, it's an honest and a good question to ask, because you need to know what you want and what you're not okay with. But again, I think it's realistic also that cytoreductive surgery has the possibilities for these things, and especially a repeat cytoreductive surgery. The amount of scar and adhesions, yes, bowel injury is possible. You may need drains, you may need an ostomy. So those are very real options. And again, case by case basis, discuss it with your team. And if you don't want those things, then I think you also need to have the conversation of what life looks like, what your goals of care are without a repeat cytoreductive surgery.
For a patient on systemic chemo, are there certain things they need to be mindful of? Many of us patients want to do everything we can in terms of boosting our immune system, maybe alternative treatments. And so the specific questions here, multivitamin, tea, turmeric, mushroom supplements, mistletoe, can those be taken while on systemic chemo?
I highly encourage you to ask that of your oncologist. I'm not going to, interfere with their treatment plan. So if they do not like or do not recommend those additive supplements for various reasons, you need to discuss it with them. In our practice and when undergoing surgery, yeah, if you're in prehabilitation or if you're recovering, you want to take a multivitamin, I'm okay with that as long as we're checking up, you're in with your primary care doctor. They're checking your blood work and checking your vitamin status. You can have too much of a good thing, right? I don't want you taking magnesium if your magnesium's normal and now it's high. And the same thing goes for potassium supplements. Some of these other ones, these nutraceuticals, again, you need to just discuss with your team if you're on them. Some of them have increased bleeding risks. So I do limit in the perioperative period, so around surgery, I don't allow our patients to be on them. So I encourage you, yes, explore them, but do that in conjunction with traditional therapy and make sure that it doesn't interfere with that therapy.
Okay, thank you. Next question, relates to, now I lost it. Scroll down on me. You've mentioned several times, and we all know it firsthand on what a rare disease it is, and the isolation that comes along with having a rare disease. The question is, do you as a medical professional caring for us with this rare disease also feel with isolation and misunderstanding when you're dealing with other medical professionals?
Wow, I really appreciate
You can guess who asked that question.
Thank you for that question. I love addressing these kind of hard questions. yeah, sometimes I do feel that as a provider. It is hard. And I have to be very honest, as a PA, when I went to school, 10 plus years ago, I didn't know what PMP was. That's not what I was trained in. As a PA, I was trained in primary care. I learned about oncology from a very general perspective. And then fortunately, I knew I wanted to be a part of oncology, and grew that knowledge base, found experts, and wanted to be a part of that team. But yeah, sometimes in the oncology world, even within our world, this knowledge is not common base. There's awareness, and it is growing. That awareness is growing. But I think that's exactly why we're here today, right? We're increasing that knowledge, we're increasing that awareness. And just like I talked about today, is there are options. Ask those hard questions, seek those second opinions from institutions that are also on the same page as you, that want to push those boundaries and find what else works. So I think academic institutions, high volume institutions that are exploring these options, I think we need to give them our support as well. So I can definitely say from my personal experience, yeah, I'm going out there. I'm going to Houston in a couple of weeks, and I'm going to present, treatment alternatives for low-grade PMP. I want to get the word out there to other PAs in oncology who may not know this. Again, I think the more we talk about it, the more chances that we're going to have, the more awareness.
Yes. And so what can be done to educate other physicians about, PMP, to diagnose better and support patients better? Even the other oncologists, particularly the medical oncologist, so many times our patients get told, it doesn't matter. We treat it the same anyway.
Yes, I hear you. So I think it's forums like this. We also have our own community as well. So there are the surgical oncology groups, there are oncology groups, there are major ones for peritoneal surface malignancies. So yes, they talk amongst themselves, they're the experts, and they're pushing the envelope, and they're researching, and they come up. But then we have to disseminate that information. So again, forums like this help us do that. We have conferences with general oncologists or community oncologists or primary doctors, gastroenterologists who do colonoscopies, general surgeons who do the appendectomies. So yes, that is part of our duty. Absolutely. I believe that. I think as a provider, it is my duty to talk to other providers, and again, disseminate that knowledge if I have it. We write lots of papers. We write lots of papers for other providers to read. And then we do our conferences, we do presentations, we do lectures. So I think that's the best way to continue getting that word out.
Thank you. Can you talk a little bit about a patient that has had surgery but not HIPEC, and considerations for a patient in that situation?
I feel I'm a little lost in that question. I'm really not sure where to start on that one. Yes, there are some cases where cytoreductive surgery are done, but HIPEC isn't. I'm not sure what that question really.
Yeah, it's the question is what if you don't get HIPEC?
But you have cytoreduction, or is it?
I believe so.
Okay. Yeah, so I think we have to address the fact that some patients, get appendectomies or removal of the appendix. Some get their colon removed in addition. Again, it depends on your tumor type. Some cases, people have a debulking surgery without HIPEC. This is a treatment decision that is made on a case-by-case basis by that expert surgeon, by that surgeon who does treat peritoneal surface malignancies. I'm sure you're all acutely aware that there is still controversy when it comes to HIPEC. But again, for low-grade PMP, by expert consensus in the United States and Europe and elsewhere, CRS HIPEC, the combination, is considered standard of care for low-grade PMP.
Thank you. Can we talk a little bit, or can you talk a little bit about the post-surgical course? What are the expectations for recovery? What are some things to avoid?
Sure. Here, I'm going to share my screen again then. Okay, so when you return home, so after your hospital stay during the recovery, right? That's what the question wanted to address. I specifically in my practice, in general, this is an average, it's going to take about 6 to 8 weeks for you to maybe feel 50% of your baseline. And again, I have to be very, very honest. I had a patient just yesterday telling me that my, average projections were pretty accurate. This doesn't apply to anyone. It's an average. Some are going to be better. Some are going to be worse. So about 6 to 8 weeks from the surgery for you about 50% of your baseline. And again, that's an active recovery, but it's very, very slow. Remember, it's a marathon that you never trained for. So your body is in this state of complete depletion, where it needs to try and recover from an injury. Surgery is an injury, not to mention the cancer. And then I would say about 6 months to a year before you really feel like yourself again. It is a slow recovery, but it can be an active one. So some patients, and that's why I wanted to bring this up, we focus again on what we did before surgery, refocus now on, in that first 6 to 8 weeks, one, battling the complications of surgery. Okay. Well, how did it immediately affect you? Your bowels were just touched. They do not like being touched, if I can put it plainly. Okay. So a lot of patients have ileus after this. They have poor nutrition or absorption. They have terrible diarrhea after surgery. So that first 6 to 8 weeks, I think, is really about focusing on managing those post-operative complications. There's also wounds, major fatigue, physical deconditioning, okay, that we need to battle. So how do you battle it? We refocus on the hydration, your nutrition, the exercise, again, exercise modified. So I do think you should be your immediate concentration in the first 6 to 8 weeks. Once that's managed, right, the appetite is returning. You can increase your caloric intake. You're walking a little bit more. That's when we can go into a true active recovery from the 8-week mark to the 6-month mark, where you refocus now about gaining your baseline, your new baseline back. So visiting nurses are a huge part of this. I highly recommend that for my patients, it's standard. If you go home after CRS HIPEC, you're going home with a nurse because they're my liaison. You've never done this before. The nurse has seen this before. So you may think that, oh, I don't need to complain about this, but the nurse, this is a red flag. Okay. So that's why they're helpful. That, and you don't want to manage your wound and drains if you have them, or other tubes that you might have. They take your vitals, they help you with your blood work, they make it convenient. Highly recommend it. And then obviously direct communication. Okay. Nutrition. Some patients are, right after surgery, you might have a tube down your nose and you can't eat. And then that first 6 to 8 weeks is all about gaining your appetite back and going from a liquid diet to a soft one, and then slowly progressing. So again, case by case basis, ask the questions of, why do I have to wait? And what is the benefit of waiting before I keep advancing my diet? I think I'm going to avoid TPN and tube feeds for this question at this time. And then obviously hydration. This is all in that 6 to 8 week period. It's key. We got to stay on top of it. My patient standard, I check blood work every week. You may not feel dehydrated or you think you're drinking enough, but your kidneys need more. Bowel routine, I touched upon this. Again, it's a constant battle of managing these complications and symptoms right after surgery. So that 6 to 8 weeks is a constant communication with your treating team. And if you're not, ask, call, find someone that is going to be in constant communication with you during that first 6 to 8 weeks after this major surgery. Okay. Post-operative visits, that's a big one. So standardly for us, I see patients 2 to 3 weeks after the surgery. but I call them within 48 hours of discharge. So that's standard for my practice. And if you feel like, again, I said, be honest, if you're not getting your questions asked, you all need to call. You also have power as that patient to be in charge of your care. So I highly recommend that. These are just some more resources that I have for patients of who to call and when in the postoperative period. Like I said, I might be your go-to for your surgical team, but I am one person on a team of many. So I want to rely on my palliative care team in my postoperative period. I want to rely on my nutritionist, my ostomy nurses, they're experts, integrative oncology, and I'm not ignoring, I put behavioral health in there. I'm relying on my therapists as well. So I think we need to have check-ins with all these people. And last but not least, your PCP. So again, standard in my practice is within discharge, you need to see your PCP within a week and reestablish. Because they're going to help us manage you top to bottom, inside and out.
Yeah, Shannon, for those that are traveling from out of town, how do you coordinate the visiting nurse?
Yeah, we have lots of patients that are from out of state, or even Pennsylvania is a pretty big state. I have patients that are 4 or 5 hours away. So typically what I tell you as a heads up before we do the surgery is that if you live several hours away, that at discharge, if it's not a major inconvenience, I do like them to stay at one of the hotels that are right on campus of our hospital, so that you can do your own trial of how you do on your own. Okay, so these are patients that are going to go home and not to a nursing facility. So see how you do at the local hotel. It's called the Family House, which is really nice. Stay there for a couple of days, again, if it's not a major inconvenience. And see how you do. And then before you're even discharged, we set up the visiting nurse. So we rely on your local oncology team if you have one, or the PCP, and sometimes both. They help us manage that. And we give them standard orders before you even leave. So again, it's just about constant communication. They have our phone number, we have theirs, you have their phone number, and they have regular check-ins. The blood work gets sent to us, the vitals are given to us. So it's just communication, and that's how we manage these out of state or these far away cases.
And will the surgical the surgeon keep managing the patient even if they're out of town?
And if the patient is out of town.
Correct.
Okay.
Patient's out of town.
So I'm not going to speak for other groups. For my practice that I'm a part of, if a patient had CRS HIPEC with us, I prefer that we are intimately involved. So yes, I've had patients that are very far out of state, but I make sure that I set up beforehand an agreement with the local team that this is what to expect, this is my phone number, and that we want to be in constant communication. And I think it works very, very well. We get the information we need. The local team is grateful because this is something very complicated. They're not left in the dark, and they have a kind of a basic guideline and then a resource to help manage. So I think, again, in my practice, I rely on my local team for a lot. They do the orders, they do physical exams, they do a lot of that because I can't order, no one can, right? If you're an MD or a PA in Pennsylvania, I can't order a CAT scan in Ohio. I can't order pain medication in Ohio. So having that local team is beneficial to everyone involved. And then open communication, setting it up beforehand, foreseeing this.
We've had several comments on wondering if we could get your checklists or access to your wonderful publication. Is there a way for our patient group to access your materials?
Yeah, so let me talk with the marketing team and our legal team about what I can make of public interest. So I'm sure that there are parts of this that we can put on our website to make as a resource. I have this in paper form, and anyone who gets a consultation, we mail it to them. Anyone who just comes for a tumor board opinion, we mail that to them. So I'm not trying to hide anything, don't worry, but I will make it available.
Appreciate it. Yeah, no, we'd love to link if you post it to your site.
I think we have one educational material that I think we gave to the PMP Pals network, but yeah, let me see if I can't share more.
Okay. And then just real quick, circling back on the patient situation that did not have HIPEC, and they may be at a facility that doesn't routinely, provide HIPEC. What advice can you give to this patient about, potentially, having a conversation with their surgeons about the need for HIPEC?
I think you need to be prepared to hear various answers when you ask hard questions. So you may notice some variations in treatment recommendations, and that can sometimes be unnerving. So yes, second opinions are encouraged and welcomed, but sometimes, like I said, it can be unnerving if you get different answers that leaves you more confused than when you started. So all the more reason to use forums like this, connections like this. This network, I think, is what's going to guide. I've looked up PMP Pals up and down. I love this resource. So I think using that and talking about it a little bit more. So go to that surgeon, ask why you specifically didn't have HIPEC. And prepare yourself going in, right? Read some of those materials so that you have a baseline or a foundation of an understanding. Ask, and then I would ask that team, well, what do you think about, who would you recommend then I speak to if I want to know a little bit more about HIPEC? And again, if you don't get the answer that you need, or it's more confusing, then search more, research on your own on forums like this, on PMP Pals. There are very helpful guides on how to do that. I'm sorry, I wish I could give you a more specific answer, but I'm not possible on this kind of forum why someone wouldn't get HIPEC or why a surgeon didn't do that. I think it's a very intimate question and answer to have.
Thank you. Another miscellaneous question. You mentioned the living wills before. What about a healthcare power of attorney?
Yes. So if you need a power of attorney, you can designate that in an advanced directive or just have one right now, if that's something that you think you need. Yes, I explore it. I highly recommend living wills and advanced directives, especially when undergoing major treatment.
Okay.
Power of attorneys, in case anyone doesn't know, a POA, power of attorney, is not needed in all cases, but it's something to discuss if you think it pertains to you. So again, a case by case basis. It was just asking why, not how.
Right.
Okay.
Right. Just, yeah. Let's see. If you're NED and suspect a recurrence, how long could you wait if you're low grade to have future treatment?
Oh yeah. So case by case basis, I think I'm becoming like a broken record. Sorry. So, and even in my practice, we take this on a case by case basis. So you have a low grade PMP with recurrence. I think we've talked about this incessantly, is that these are slow growing, and a recurrence could be one little tumor nodule, and you had surgery 5 years ago. You're not going to jump into CRS HIPEC again. And it can be very unnerving. I do not want to be insensitive to that. And I think that, again, in my practice, that's a very personal conversation I have with my patient and their support members about how to manage that anxiety. A lot of my patients call it scanxiety, and it breaks my heart every time they come in. They're so happy to see us, but the first thing out of my mouth that they want is whether or not there was anything on that scan. So yes, I think you need to have that honest discussion with your team specifically. If you're in that subgroup of patients that have recurrent low-grade PMP, ask the pros and cons or the risks and benefits of watching and waiting versus when do you go back into surgery? It's a very good question to have. And what is the benefit or the risk of using scans, CT versus MRI? How often do I do this? And how do you make that decision to go back to surgery? That is a very specific answer between a patient and their provider. It is a difficult one to make in our practice. It's a combination of what is the patient's goals of care. Can they tolerate a repeat surgery? Are they a candidate for a repeat surgery? And then if all of those answers align to yes, let's do a repeat surgery, then we discuss the risks and benefits of let's wait a little bit longer. Let's get even further from your last surgery before we dive into another major procedure. And again, specifically to low-grade PMP, you have that luxury to have that discussion.
Can you talk a little bit about the nuance between recurrence and disease that was intentionally left behind?
Okay, so in low-grade PMP, remember when we talked about PCI and CC score? So in low-grade PMP, sometimes you can have an incomplete debulking where you leave these little tumors behind and have what's called a CC1. And that is, again, a decision that you and your surgeon make, or you as the patient allow your surgeon to make for you during the operation. And it's to spare you from a morbid procedure. So some patients have these little tumors all over their small bowel, and you need your small bowel in order to survive. You can make resections of it, but in very small amounts. You need a lot of your small bowel in order to survive, or you get something that's called short gut. And it is a life-changing procedure to have. So purposely leaving disease behind is a calculated decision made between you and your surgeon of whether or not you, one, can have it done and why you have it done. And then comparing that to what recurrence, Adele, right?
Yes.
So recurrence would be someone who had a complete macroscopic debulking, right? So all visible disease was removed. They go into surveillance, and during surveillance, either a tumor marker starts climbing, there's something suspicious found on scan, and then a clinical decision is made either based on what you're seeing, the trend, or you do a biopsy and you confirm that disease has returned.
Does your team accept patients outside of the US?
Yes, yeah. We've had people from Canada. I think I saw that one pop up.
Yep.
Yes, we've seen patients from Canada. I think it's important to know that our tumor board, we do a very detailed review of charts, and we provide you with what that recommendation is via like a video visit if you're too far away. But we also help you know what your local options are. That's what a multidisciplinary tumor board should look like. Not just what we do, but also what is available to you in your location. I do remember we have had patients from Canada, and they didn't come to us for our recommendation. They got their care locally. And the same things happen within the States. So it's really about getting you the best possible care that is convenient, that works for you.
Thank you. Is the CC score cumulative disease or a singular instance? Or is you can see the question in the chat, Shannon, or is disease singular?
Okay, I think I understand. So the CC score, CC0, remember, is no visible disease. CC1 is a visible tumor less than 2.5 millimeters, and that can be in more than one section. Does that help? So it's not cumulative. It's not, I have a 0.5 millimeter and another half. No, it's
okay.
a
singular bunch of many.
Yeah, okay. Up to 2.5. And then the abdomen and pelvis is broken down into a grid, and then you can measure it. Yeah, that's how you get PCI, right? It's, you look in all of those areas and you count. And the same thing with CC. For instance, in a low-grade PMP, if there are multiple miliary tumors left on the small bowel, so 1 millimeter here, 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 etc., that's still a CC1.
Okay, perfect. Great clarification. Well, Shannon, with that, you have been so generous with your time this morning on a Saturday morning. You know, we can't thank you enough. And I mean, not only your technical expertise, but, you know, the compassion and the heart that you have for the patients really shines through. And, you know, we greatly appreciate it.
Absolutely. I was really, really happy to be here. Again, if I can be of any help in the future, please let me know. Happy to be a resource.
Absolutely. So with that, thank you, everybody. And as a reminder, we are on break. So no Zoom this Wednesday, no Zoom a week from today, but then we'll be back the Wednesday after that. So take care, everybody. Thank you for joining today.
Have a good one.
You too. Bye.